Sharon Pabody, Elena Billingsley. Menopause and HRT. Sharon Pabody, Elena Billingsley. Will cover what is the menopause, diagnosing the menopause management, non-hormonal HRT, premature menopause, program patient experience presentation case studies, CSA style. Quiz. Menopause, what and when? The menopause may be natural or induced. Natural menopause is the permanent cessation of the menstrual cycle due to loss of ovarian follicular activity. Only known retrospectively 1 year after the last period. Average is 51 years. Induced menopause specific treatment, for example chemotherapy or radiotherapy. Oophorectomy. Treatment with gonadotrophin-releasing hormone, GnRH, analogs. Diagnosis, symptoms: short-term musculoskeletal vasomotor flushes, night sweats, insomnia, sexual dysfunction, vaginal dryness, dyspareunia, decreased libido, musculoskeletal, joint aches, fat redistribution, psychological, depressed mood, anxiety, irritability, mood swings, lethargy, difficulty concentrating. Consequences of the menopause: long-term osteoporosis, 1 in 3 increase in risk of fracture, cardiovascular disease, knee and stroke, most common cause of death greater than 60 years. Oophorectomized women have 2 to 3-fold risk of CHD, urogenital, lower urinary tract and pelvic floor atrophy leading to frequency, urgency, nocturia, incontinence, recurrent infections. Vaginal atrophy. Investigations: FSH is only used if diagnosis is in doubt. FSH greater than 30 U/L. Don't do LH, estradiol and progesterone as not helpful. TFTs if confusion about symptoms. BMD if significant risk of osteoporosis. Management, non-hormonal. Lifestyle advice. Avoid hot drinks, especially caffeinated ones, and alcohol. Stop smoking. Fans and layering. Use of vaginal moisturizers, for example Replens MD and Silk registered. No evidence that diet, phytoestrogens, affects symptoms. Management, non-hormonal. OTC remedies. Black cohosh. Estrogen-like effect. May help with emotional symptoms. Interacts with antihypertensives and risk of liver failure. St. John's wort. Recognized antidepressant effects. Lots of interactions. Management, non-hormonal. Licensed. Clonidine for hot flushes. SEs: insomnia, dry mouth, dizziness, constipation, drowsiness. Unlicensed. SSRI, venlafaxine, for mood swings, vasomotor symptoms. Gabapentin for musculoskeletal, SEs: dizziness, fatigue, tremor, weight gain. HRT counseling about risks and benefits, contraindications to HRT. Different routes/types of HRT. Deciding on appropriate HRT, systemic or local. Following up patients on HRT. Stopping HRT. Benefits of HRT: proven relief of menopausal symptoms. Prevention/treatment of osteoporosis. Reduced risk of colorectal cancer. Risks of HRT: breast cancer, VTE. Increased by 26% in greater than 50 years taking combined HRT for greater than 5 years. Returns to baseline 5 years after stopping. VTE. 2-3x with oral HRT, highest in first year. Absolute risk remains small. Risk of acute coronary events in women with pre-existing CVD in first year. Risk of CVA. Women's Health Initiative. Launched in 1991. Effective postmenopausal HRT, diet modification, and calcium and vitamin D supplements. Heart disease. Fractures. Breast and colorectal cancer. Combined HRT. ME, CVA, VTE, breast cancer. Colorectal cancer and fractures. Estrogen alone. Left-right arrow, ME, colorectal cancer. CVA, VTE. Breast cancer. Fractures. Million Women Study. National study involving over 1 million women aged 50 and over. Main focus is effect of HRT use. Over 1 in 4 women in target age group are in study. Risk breast cancer in women using HRT, particularly with combined HRT. Risk breast if HRT peri rather than postmenopause. Between 1996 and 2001 women were asked to participate when they received their invitation for breast screening. Contraindications to HRT specialist initiation. Hormone-dependent cancer, endometrial cancer, current or past breast cancer. Active or recent arterial thrombotic disease, CVD, CVA. VTE. Otosclerosis. Severe active liver disease, oral estrogen. Undiagnosed breast mass. Undiagnosed abnormal vaginal bleeding. Dubin-Johnson and Rotor syndromes. Relative contraindications. May require extra supervision. Uterine fibroids. Endometriosis. Hypertension. Migraine. HRT local symptoms vaginal estrogen systemic symptoms uterus. No uterus. Combined HRT. Estrogen only. Oral or non-oral. Perimenopausal. Postmenopausal, greater than 12 months since LMP. Sequential or cyclical HRT. Continuous combined HRT, no bleeds. Tibolone. Local symptoms. Vaginal dryness, soreness, dyspareunia, urinary frequency/urgency. Various preparations. Pessaries for example orthogyne cyst. Creams for example Gynest registered, Ovestin registered. Tablets for example Vagifem registered. Rings for example Estring registered. Some damage latex condoms/diaphragms. Non-oral estrogens all estradiol 17 beta. Avoid first-pass metabolism in liver. Available as patches. Gels, less irritating than a patch. Implants, last resort. Low, medium and high doses. Potentially more suitable for women with liver disease or gallstones. At risk of VTE. With DM and others with raised TGs. On enzyme inducers. First line for women with migraine and malabsorption, oral estrogens 3 types low, medium, high doses start at low dose. Conjugate equine estrogens, Cs. Estradiol 17 beta. Estradiol valerate. Low, medium, high doses. Start at low dose. Progestogens, 3 types. Testosterone analogues, C19, androgenic SEs. Norethisterone, levonorgestrel, Mirena, norgestrel. Progesterone analogues, C21. Dihydrogesterone, medroxyprogesterone acetate, EPA. Newer, derivates of norgestrel. desogestrel, norgestimate, gestadine. Mirena is licensed for endometrial protection alongside estrogen replacement for up to 4 years. Why bother about type? Oral, combined or alone, transdermal, combined, and intrauterine? If patient gets PMS-type symptoms. Can alter progestogen to less androgenic type. Can alter route of progestogen, for example to ES. HRT local symptoms vaginal estrogen systemic symptoms uterus. No uterus. Combined HRT. Estrogen only. Oral or non-oral. Perimenopausal. Postmenopausal, greater than 12 months since LMP. Sequential or cyclical HRT. Continuous combined HRT, no bleeds. Tibolone. Perimenopausal postmenopausal. Sequential if regular period or cyclical if infrequent, tridestra. Progestogen 12 to 14 days/month. 5% to 15% have no monthly bleed. Tridestra gives 3 monthly bleed. Postmenopausal. Continuous, no bleed HRT. Require investigation if persistent bleeding. Greater than 6 months. Heavier bleeding. Bleeding after a period of amenorrhea. Tibolone. Tibolone. Synthetic steroid that properties of estrogen, progestogen and testosterone. For prevention of osteoporosis in postmenopausal women. For short-term use in premenopausal being treated with GnRH. Increases risk of stroke in greater than 60 years, similar to conventional HRT in younger. Side effects of HRT: nausea, vomiting, abdominal cramps, bloating. Weight changes. Breast tenderness. PMS-like syndrome. Sodium and fluid retention. Glucose intolerance. Altered blood lipids. Mood changes. Headache, migraine, dizziness. Leg cramps. And more. Testosterone. Women who have had Ta plus VSO may experience testosterone deficiency, abrupt rather than gradual fall in levels. Can offer replacement. Implants, need to monitor levels before each change. Patches. SES, hirsutism, deep voice, cleidomegaly. Must be on estrogen, but not say. Questions to ask. Does patient want HRT? Is the patient informed about risks and benefits? Are symptom local or systemic? Does the patient have a uterus? Is the patient peri or postmenopausal? Which estrogen? Which progestogen? Premature menopause classification. Normal, 45 to 55 years, average 51 years. Early, 40 to 45 years. Premature, less than 40 years. Unpredictable, so need to continue contraception. Diagnosis. Minimum of 2 FSH greater than 30 U/L at least 1 month apart. Other investigations: pregnancy test, DFDs. Prolactin for hyperprolactinemia. Autoantibodies, ovarian/thyroid/adrenal. Karyotyping if less than 30 years for Mosaic-Turner's syndrome. Baseline DEXA, then repeat every 2 to 5 years. Baseline fasting lipids, yearly, depending on RFs. Follicle tracking on USS, fertility, risks of premature menopause. Life expectancy is reduced, 2 years. Untreated. 50% higher risk of osteoporotic fracture between 50 to 70 years. Risk of CVD compared to women of same age. 260% risk of dementia following removal of a single ovary by age 38. Risk Parkinson's. Treating premature menopause. Estrogen replacement with progesterone. Given most conveniently as co-CP. Continue until aged 50 years. Follow up on HRT 3 monthly until stabilized, then yearly. At follow-up, check. Symptom control. Bleeding control. Side effects. BP, BMI. Reassess risk versus benefits. Breast awareness, duration of use, minimum dose for shortest period. Symptoms last between 2 to 5 years, so try stopping at 3 to 5 years. Woman can continue longer as counseled. Risks. Stopping. Ensure progesterone dose offers endometrial protection. Ifing slowly, high-dose estrogens only. No evidence of how best to stop, i.e. gradual versus sudden. When stopping HRT, warn patient of 2 to 3 months rebound vasomotor symptoms, HRT, sudden severe chest pain, sudden dyspnea, unexplained swelling/severe calf pain, severe stomach pain, neurological effects, hepatitis, jaundice, hepatomegaly, systolic BP greater than 160, diastolic greater than 95 mm of mercury, prolonged immobility, detection of RF that is contraindication. Stop 4 to 6 weeks before any major surgery. Summary. HRT is good for menopausal symptoms and osteoporosis prevention. Non-hormonal treatments can help with symptoms. HRT is not necessarily systemic. Treatment must be regularly reviewed. Stopping contraception around the menopause. 1. Contraception may be stopped at 55 years. Women using hormonal contraception, and have regular bleeding at 55 years should continue with contraception. Ideally, women over 50 years should switch to POP, implant, LNGs or barrier method until aged 55, or until menopause confirmed. Stopping contraception around the menopause. 2. FSH is not a reliable indicator of menopause in women using combined hormonal contraception. Women with premature menopause may need specialist contraceptive opinion. Ovarian activity may return spontaneously. Stopping contraception around the menopause. 3. If using non-hormonal methods of contraception, women over 50 years can stop after 1 year of amenorrhea. Women under 50 years can stop after 2 years. Women over 40 years with a copper O, greater than or equal to 300 square millimeters copper, inserted at or over age 40 can retain the device until the menopause. FSH is best used in women aged over 50 on progestogen-only methods. Need 2x FSH greater than or equal to 30 U/L, 6 weeks apart, and then contraception can be stopped after a year. HRT and contraception. Women should not rely on HRT for contraception. POP can be used to provide contraception with combined HRT. Women using estrogen replacement may use LVGS, Mirena, to provide endometrial protection. When ES is used as progestogen component, it must be changed no later than 5 years. License says 4 years. Resources: ELFH Learning Modules. Menopause and HRT Innovate, Volume 2, Number 1, pages 10 to 16, 2009. Common Problems of the Menopause Innovate, first published online May 16, 2012. DOI 10.1093/innovate/INS075. http://www.menopauseMatters.co.uk/ http://www.menopauseMatters.co.uk/3.php http://www.millionwomenstudy.org http://www.nlb.nih.gov/we/ FSRH Guidance, Contraception for Women Ages over 40 Years, July 2010. Quiz. Question 1. Which one of the following conditions is least likely to be the cause of postmenopausal bleeding? Atrophic vaginitis, cervical intraepithelial neoplasia, CIN, hormone replacement therapy, tamoxifen therapy, urethral caruncle. Question 2. The age at which a woman reaches the menopause is related to age at menarche, ethnic group, family tendency, parity, regularity of cycle. Question 3. A 52-year-old postmenopausal woman comes to see you regarding her menopausal symptoms. She is suffering with intrusive hot flushes and these vasomotor symptoms are getting her down. She does not want to take HRT but would consider another medicine, if it would help. Which one of the following have an evidence base for its use in this situation? Amitriptyline, flupentixol, mirtazapine, phenelazine, venlafaxine. Question 4. A postmenopausal woman comes to see you complaining of frequent intrusive hot flushes. She does not wish to take HRT and is keen to try natural alternatives. Which one of the following alternatives has the most evidence base for its use in this situation? Dong Quai, evening primrose oil, ginkgo biloba, kava kava, red clover. Question 5. A 54-year-old lady comes to see you to discuss treatment for the menopause. Her last period was 18 months ago. She has no significant past medical or surgical history and is keen to try HRT as she is getting troublesome hot flushes and vaginal dryness. Following full discussion and counseling, she has no contraindications to hormonal treatment and is keen to try a suitable regimen. Which one of the following is the most appropriate to prescribe? Continuous combined HRT, low-dose CoCP, estrogen-only HRT, sequential HRT, topical vaginal estrogen. Question 6. A 52-year-old lady comes to see you. Her periods had become light and infrequent for several years and then stopped about 5 months ago. She has no other significant past medical or surgical history. Her family history reveals no significant cardiovascular or thromboembolic disease. She is a lifelong non-smoker. She has had 2 pregnancies, both of which resulted in healthy children. She currently feels well. On further questioning, she has had some mild flushes but these are not troublesome. Examination reveals a BP of 118/76 and a BMI of 22. Question 6. Which of the following pieces of advice should you give? Blood tests for FSH, LH and estradiol should be sent to confirm she is postmenopausal and guide her management. Her periods have become irregular and ceased because of waning estrogen production, and that HRT is indicated as it will counteract this and help with the flushes. If she is worried about pregnancy risk, then a low-dose CoCP would be her best option, as it would treat her flushes as well as provide contraception. She is postmenopausal and therefore does not require any contraception. She is probably postmenopausal, but she should continue to use contraception until 12 months have elapsed since her last period. Question 7. Menopausal assessment symptoms but does not wish HRT. Clonidine, I. Gabapentin, alternative RX. Decision to start HRT. Urogenital symptoms only, 2. Systemic HRT. With uterus. Without uterus. Postmenopausal. Perimenopausal. 3. 4. Regular cycle. Infrequent cycle. V. Vi. Question 7. Management of menopausal symptoms algorithm. A. Alendronate. B. Beta blockers. C. Continuous combined estrogen. D. Danazol. E. Local estrogens. F. Long cycle HRT. G. Selective serotonin reuptake inhibitor. H. Sequential HRT. I. Strontium ranulate. J. Systemically absorbed estrogens. For each of the following stems relating to key points in the algorithm, select the correct option to complete the algorithm from the list given. Each option may be used once, more than once, or not at all. Question 8. Which one of the following is true of the menopause? All symptoms respond to counseling. Flushes should not be treated with systemic estrogens. Hormone profiles are needed for confirmation in most cases. Hot flushes may respond to clonidine. Loss of libido is due to estrogen withdrawal. Phytoestrogens are as effective as HRT. Tibolone is not effective for loss of libido. Question 9a, Clonidine B, combined hormone replacement. For each case below, choose the single most appropriate treatment from the given list of options. Each option may be used once, more than once, or not at all. A. Clonidine. B. Combined hormone replacement. C. Dietary modification. D. Hypnotic preparations. E. Mineral supplements. F. Estrogen-only HRT. G. Psychological support. H. Referral to psychiatrist. I. Regular exercise. J. Vaginal lubricant. K. Vaginal estrogens therapy, HRT. Question 9. A 52-year-old married woman who has a family history of breast cancer has been experiencing mild dyspareunia for a few hours following intercourse for the last month. She is worried about using hormones. A 45-year-old woman who has had a total abdominal hysterectomy, TAH, and bilateral salpingo-oophorectomy, BSO, for fibroids and menorrhagia complains of hot flushes, night sweats and mood swings. She has no other medical problems. A 72-year-old woman has experienced frequency of micturition intermittently for the last few months. Midstream urine, MSU, cultures have been persistently negative. She is well otherwise, but would like the symptoms resolved. A 56-year-old woman whose period stopped 5 years ago has become increasingly depressed. She now feels life is no longer worth living and threatens suicide.